Hello, everyone, and welcome back to the Stanford Emergency Medicine podcast. I am Dr. Manish Shah, professor of emergency medicine and pediatrics at Stanford, and I am excited to be your guest host today for this very important topic. Emergency departments see the consequences of substance use disorders every single day. For a long time, though, the job of the emergency physician was mostly to stabilize the immediate crisis and then move patients along, without really addressing the underlying addiction. Over the past decade, that paradigm has begun to change. Increasingly, emergency physicians are helping start patients on real treatment for addiction. Few people have done more to shape that shift than today's guest. Dr. Gail D'Onofrio is the Albert E. Kent Professor of Emergency Medicine at Yale and the founding chair of Yale's Department of Emergency Medicine. In 2015, her landmark study demonstrated that starting buprenorphine in the emergency department helps far more patients get into addiction treatment. That work helped change practice across the country. In 2023, she was elected to the National Academy of Medicine for her contributions to improving care for people with substance use disorders. Today, we explore how emergency medicine became a critical entry point for addiction treatment and what that means for the future of our field. Dr. D'Onofrio, welcome to the podcast.
Thank you. I'm happy to be here.
So you had a career before medicine, nursing, running your own firm, consulting at Hewlett-Packard. What pulled you back toward clinical work, and what was it like walking into the emergency department at Boston City Hospital, now known as Boston Medical Center, in the middle of the crack epidemic?
So it was a long, circuitous route, but it was actually, I've always wanted to be a doctor, and I was going to be a doctor, and somehow I got a little bit swayed early on. I think it was because it was really a long time ago. There were very few women in medicine then, and I went and I thought I would do nursing at Duke, and then I realized, no, I really wanted to go to medical school, so I was a dual major, and that worked out well. And just for other life circumstances, I ended up holding off going to medical school and went to Boston instead and became a nurse there and critical care nurse, and Nurse Traineeship Act sent me to graduate school for free, really learning about education and health policy, which I think has helped frame my work throughout the rest of my career. So I've learned a lot, and I think a lot of skills along that way. But the focus, I always wanted to be a doctor since I was tiny. Who knows? I had bad asthma. I went to a doctor who happened to be a woman, which was unheard of in the 50s, and it was really amazing. And I think I must have had something in relation to her that why I wanted to do it always. So then bringing me to Boston City, I loved Boston City Hospital and my time there, but it was really a zoo. It was chaotic. I was the first real year where we went through a match in emergency medicine. The faculty were not emergency medicine trained, most of them, although Dr. Peter Moyer was our chair who came from New York and was phenomenal. We had many people who were infectious disease doctors, internal medicine, whatever. They didn't know how to do anything. And we were the trauma center of the city, and it was horrible amounts of trauma. Like, it's hard to imagine how we would get 4 or 5 gunshots or stab wounds in an hour. Like, it's pretty amazing for now. We don't even know how that is. So it was relatively scary, but the small group of us who learned as much as we could, sometimes in a lab with animals, would come back and do it. And we just had to move forward. So we knew we had to, or no one else was going to do it. And that really set the tone. As I'm sure you're going to ask me, like, what did I see, right? So other things are that I wanted to be a trauma surgeon at first. I thought that's what I may do. A lot of trauma surgeons talked me out of that because at the time you had to live in the hospital. You couldn't go home. We were up all night operating when I was a student with them. And they said, it's not compatible with life. But I loved it. And they said, this thing's coming and it's called emergency medicine. You're going to be great at it. And I go like, what is that? And they said, you can do all the procedures, but you're going to have a better life. And it's just something you're going to enjoy. And so really of a wing and a prayer, I did it. I had no idea. There wasn't anywhere I could go and say, what's emergency medicine like? Whatever it is. These people who were great surgeons who actually operated in Vietnam and in other wars said to me, this is where you need to be. go there. It'll be perfect. So I did.
Mm-hmm.
And I learned a lot. So I liked trauma and I was doing the trauma. I did as much as I can. But honestly, I learned how to be really good at saving people's lives. But a patient would say to me, Doc, don't you remember me? Someone who comes in with a stab wound. I was here last month who had also been in the trauma room. And it was just one patient after another. All it was substance use. I didn't go there thinking I want to do something with addictions. I went there wanting to do procedures and help people out of injury. And then I found out that wasn't really going to help them. It's like the old public health, paradigm where people keep upstream throwing people in water and you're kind of fishing people out. And then you finally say, I got to go upstream and find out why they're all throwing them in the water.
Yeah.
So that's where it started.
Wow. It's really inspiring to hear how all of those variety of experiences really shaped your interest in what you're doing now. And really also to hear how you were at the forefront of emergency medicine and also a pioneer when it comes to research. And so, relevant research questions often emerge from the observations that we see at the bedside. And you started to touch on this just a moment ago. And I'm curious to hear, was there a specific patient or a pattern that made you think this is a research question worth getting an answer to, and not just a clinical frustration?
Right. So my first real project was around alcohol use disorder and seizures related to withdrawal. And I was told, as I did my internship there in medicine, because emergency medicine was a 2 through 4 program, that you had to give 5 days of Dilantin. And I said, that makes no sense. Like, why? When you think about Dilantin as an antiepileptic, you can actually hurt people by keeping to reload them. It lowers their seizure threshold. And I saw no reason why I was doing it for alcohol withdrawal. Like, what was the connection here? Gail, that's what we do. Just do it, okay? And in fact, the patients took it because we had great shelters that were near us. So our patients, when we discharged them, would go to the shelter. They would take their 5 days, and I would see the same person back the next week, and I'm giving them 5 days of Dilantin. And I said, this has got to stop. Like, there cannot be a reason for this, a real medical reason that I'm doing it. So my first trial was with another faculty member there, and whatever it is, I was a resident, and we did placebo versus Dilantin and realized that neither of them worked, as we said, so Dilantin was worthless. And around that period of time then after, and I'm a new attending, lorazepam came out, which is known as Ativan, by a company. And it was a great medication because it could be given IM, IV, and it was absorbed very well, whereas Dilantin or Valium is not absorbed well parenterally. So it was a great choice. It would help withdrawal, and maybe this would stop their seizures. The reason why is when people have an alcohol withdrawal seizure, they tend to have multiple ones after it. And once they have more than one, you don't want to release them from the ED or go somewhere or send them to detox because then they'll have a lot more and they could actually die. So it was really important to fix it, observe the patient for a while, and then decide what they wanted to do in terms of going to a rehab center or leaving, which most of the case they wanted to leave. So we did this study, and in the old days, you did everything yourself. I mean, I had $5,000, and that was my statistician, and get someone to randomize them. And another, Dr. Ulrich, another resident of mine, and a new faculty member, we did everything together. We made the little vials up in the pharmacy. We had them available. They were given with alcohol withdrawal seizure patients. And we were shocked to find out that hardly anyone had a recurrent seizure. And if they didn't get that, everyone did. So it was amazing. And so and it went into the New England Journal of Medicine, which was like, really? Like, people aspire to do that. Even today, I got a rejection from there not long ago that I go like, I can't believe I did this. But it was a changing practice. And still today, it is a question on most boards. And it is give the 2 milligrams of Ativan and let's see what happens. So it was a question. And it literally, I wasn't doing it because I wanted to do addiction medicine. I did it because it was a questionable curiosity about why are we doing this? It makes no sense. Somebody give me a reason that I'm giving these medications and how can I help people? And that was it.
Wow. New England Journal of Medicine
Yes.
as your first publication. That's
right. My
quite
first
inspiring.
real trial
quite a high
publication.
bar. I'm curious, before the buprenorphine trial,
Right.
what made you believe that the emergency department could be something more than a revolving door for patients with addiction?
Well, I was very interested in a lot of different things around addiction, and I focused a lot on alcohol use disorder or just really drinking too much, not even a moderate to severe disorder, and learning how to do interventions and just talking to people and all kinds of interventions that had to do with alcohol. And honestly, it was really circumstance that something came out from what we call a RFA or a put in. You should blanking on the name of that. So the RFA came out about from NIDA looking at drugs that you could use to screen and intervene for substance use. So I can remember calling the project officer and saying, you don't really think that the same medication that I could treat cannabis or marijuana and somebody who has heroin, because that's what they were using, or Percocets, you don't really think that's the same intervention, right? He says, well, people can do whatever they want. So I said, would you mind if I used one set of patients using people that had opiate use disorder? And I would like to think about this drug, buprenorphine. Now, buprenorphine had been around for quite a while. It had been used in France. It had been used, Dr. Swartz in Baltimore was starting to use it. Outpatient sources were, and in our Yale system, Dr. O'Connor was using it in the primary care setting. And so I heard of it, and I worked with him and Dr. Filene from internal medicine, and I said, let's try it in the hospital. Do you think we could do that in the emergency department? I thought, why not? So literally, I just went to their clinic, learned how to give it with really a nurse who was giving it most of the time, talked to patients a lot about what they liked and didn't like about it, and then said, okay, we're going to do it. And so I put the grant in, and I was very lucky. I got the grant, was awarded, and I literally gave it all out myself. So the other faculty didn't even know what I was doing. I just said, I got this medicine. They weren't that interested. I'm going to be there. I'm going to do it. So you don't have to do anything. I'm going to ask patients. And I have RAs who are going around looking for people with opiate use disorder. And so I did it. And I just, there were actually 3 different pots that patients could be randomized into. The first was the lowest level, which was referral only. But since I really was committed to not just sending people home with a piece of paper, they got a place to go that was consistent with their insurance and what they wanted, et cetera. So that was one level they could be randomized to. The second was a project that I had ongoing, Project Assert, which were substance use navigators working with people, doing an intervention to motivate them to want to change, and then a facilitator referral. So they actually called the site. They got a fax at that time, someone's coming to you. And I really thought that was going to be the best. And the last was they would get that intervention, but they would also get the medication. And it was an effective study, so an efficacy study. So they got the medication themselves, and they all went to Dr. Filene's office. So I was kind of shocked when we, did the data, and it found out that almost 80% of people were in treatment at 30 days. Like, it's amazing. Like, really? So it really, I didn't expect it to be as effective as it was. But having been the person who went there and gave it out and really saw all of these patients do well, it really was an amazing thing that I could make people feel better so quickly. And then I could want to motivate them to continue treatment moving on. And it was just a really mind-blowing experience of changing something that had never happened before.
Thank you for sharing that. When you were sharing just your journey with that, I was curious about something that you touched on, and you mentioned how you approached patients and asked their opinions about what you were proposing. And I think a lot of times as investigators, we don't think to do that. I was wondering if you could comment on that aspect of how you designed the study and what you learned from patients when you actually talked to them about what you were doing.
Well, that was true. I did that long before they really weren't involved in the trial per se. At that point, going on fast forward, we often ask patients a lot of what went well and what didn't well in order to do it. But in this case, since I had never given out this medication, I really knew very little. I just read about it. And it was very contained. There were a lot of legal aspects. So I had to take tests to be able to, we had this thing called the X waiver. I had to take a test to be able to give out the medicine. But I actually had really no experience with it. And I didn't know how the patient would feel or what would happen. So it was nice that I got to go to this clinic and work with this nurse. And I wanted to hear what they thought. I said, how's it going? Like, did you like it? What do you not like about it? Tell me more about your experiences. And they were very forthcoming. And so that was great. And I learned from the nurse, too, of the patients who came back and why they liked it and what she thought as well. So it was a good experience before I started. And I did talk to a lot of patients in the beginning of the trial, too. And I thought that this can't really work, or how does it work even in the ED setting? So originally I was literally physically in the ED for many of them because I felt like I had to be there. After a while, I figured, this can go really well, so I could do it on the phone. But just seeing people and understanding that they came with in quite levels of withdrawal, high levels of withdrawal for this medication trial. The first one had to be in moderate withdrawal. And that they could be so different in a few minutes.
Wow.
Like literally you're consenting them, but they're all over the place. Oh, yeah, if you got something, I'll try it, whatever. And you go over the whole thing with them. And then the next minute they're just sitting there comfortably having a conversation with there's nothing in medicine that really does that. I can't fix people that quickly. I just can't. For most things, you can't.
In emergency medicine, we've long defined ourselves around the acute, and stabilizing our patients and then handing them off either to the inpatient setting or back out into the community. And addiction care typically gets framed as referral, harm reduction, and then someone else's lane. Right. How does your work challenge what our field thinks addiction care is and who is responsible for managing it?
Well, that's an interesting, actually, I'm glad you asked me that because it's been a paradigm I've been against from day one, actually, that's really what we do. Having grown up in Boston City Hospital, which is really a hospital of very disadvantaged people in the community and relatively young patients, we were committed towards getting them to clinics. And that hospital had a clinic for everything I could send people to, from, sexually transmitted diseases the next day to you name what they had, I could send you to it. They had everything. And so we maybe not started a lot of things, but we were able to get people in at all times. Unfortunately, a lot of people think that, yes, that's what we do. We stabilize people and we send them on. But actually, if we did that to really acute people, we'd need about 10% of our workforce. If that's all we did was very acute things and stabilize them. So we really do more than that. And now, more than anything, the ED is really the number one place that people go for unscheduled care. And I don't care what your socioeconomic status is, you end up in an emergency department. The minute that you have something wrong and you even have a doctor to call, the answer will be go to the ED, click. Go to the ED, click for everything. So we have a real opportunity to not only do that initial stabilization or start it, but make sure that people are well on their way to whatever it is, to getting better. I mean, as you can see, we do a lot of things now. We do immunizations, right? In the emergency department, which is great because we want to make sure people get them right when they're there. We can give a flu shot anytime anybody wanted. We could give a COVID shot anytime that we want. And I'm sure you're a pediatrician. You could give other things if you needed to, vaccinations.
Yes.
So really, when you think about what I think about emergency medicine is, and I'm hoping that you and the rest of the world think, is that we're there to improve the health of the public. If you keep that in mind, that you're there, then it's a real easy lift to know what I'm going to do next. So I want to make it as easy as possible for people to have the opportunity to do well.
Improving the health of the public. Such an important thing that we do in emergency medicine. And so I'm curious then, what has to change in training, in pharmacy, and how systems are organized to do that? And specifically with what you've done, ED-initiated buprenorphine, but also even beyond that.
Right. Well, the sad thing about buprenorphine is that I published that article a decade ago, right? And right now, even there are not as many places that should be who are doing that treatment, who are offering that treatment. And overall, not just in EDs, but overall, less than 20% of people that have an opiate use disorder are on medications that are incredibly effective, methadone or buprenorphine. So why is that? There's lots of reasons. I think primarily it's stigma in most cases because it's easy. It's so easy to do that emergency physicians give out gobs of medications that can really hurt people. Half the time, we don't even know what they are, right? Half the time, there's like some shortage in some medicine, and the pharmacist will come in, we don't have that, but we have this. And you're like, what's that? Oh, it's the same class. Don't worry. I'll tell you how much to get, right? We give it, right? Even in fancy, like horrible situations that are very complicated, we kind of flow with what we have and what we do. And so then you look at something like this where you can't really hurt anybody. If they have an opiate use disorder anyway, you cannot hurt them, right? So people worry that they might precipitate withdrawal. But if you do it and people are withdrawing and you're clear about it, it's easy, but you're not going to really hurt anybody. So why people aren't doing it is an interesting question. I haven't quite figured it out, but it's mostly stigma. I believe that the best way of getting over that is one making it easy, because people don't do the right thing until there's nothing else to do, right? So first I want to make it easy for them. So we have pathways in Epic that you just press a button. It will do everything for you. It even writes your note, can write your note for what you do. And it'll tell you where to refer somebody. It's got like 3 options and you know where the patient wants to go or their insurance status or whatever. And you press the button, everything comes out. So it's really quite easy. So that's one of the things we can do, right? And the other things is we have to do a lot of monitoring feedback, unfortunately. And I can remember, again, in Boston City, I was just thinking of this last night when I was thinking about today. There was a incredible woman there who was interested in interpersonal violence and domestic violence. And back then we had written charts. She reviewed every chart that a woman had an injury. And you'd get it back if you did not write that this was not, or you didn't ask the question. Every single chart would end up in your box. So you learned very early on, not just to do it, but to document it, right? So every single chart I ever had, I just did it. No, I spoke to this woman. This is not domestic violence, or it was, and I went through the pathway that we had. But it was really her hammering it on us, and literally you were going to get it back in your box, and you were going to tell me why you didn't do that, right? Yeah. So, and I had to explain, I think I did it, but I didn't write it down, right? So I think we need to do that. I need to do something that people get that feedback back immediately and say, why didn't you do that? Why didn't you give it out? What were your reasons for not giving it out? And there are no reasons to not give it out. People can decline, of course. And all you do is say, I offered, they declined. I've given them the Narcan, the naloxone to take home. I've told them that they could come back anytime, or they could go to a variety of different places within the community. That's fine, and that takes a few minutes. But not to have offered it, particularly when, overdose is really the number one cause of death for anyone under 45 years of age. It is the number one cause of death. So, and most of the time, these are young people. So why are we not offering them a life-saving treatment? We wouldn't send people out that have MIs, myocardial infarctions. We would never send them out. We know that their risk of dying is almost approaching 5% in a month. Well, that's about where these people are, also individuals who come in with a non-fatal overdose. So, but we're willing to send them out with go talk to somebody without giving them the life-saving treatment that we would for an ST elevation MI. Think about an ST elevation MI, right? Hospitals spend enormous amounts of money to make sure that we saw an EKG within a certain amount of time, that we got people to the cath lab with a certain amount of time. Enormous amounts of money, because they would get really dinged by Medicare, and they would lose lots of money. I wish that I could get that to happen, but it's not Medicare, it's Medicaid, so it's state-run, so I can't do that. But I wish I could make that kind of of a standard and a quality measure to do it. So otherwise, I'm really at the mercy of the hospital. But people have to know that if people leave and you haven't offered them and they die, there's a major lawsuit there for the hospital and the physician. So one should think very clearly before you send someone out and not offer them treatment.
So I heard a few things with what you just shared. And one is, in medicine, as investigators, we can generate evidence, but then there can be this lag in adopting that evidence and that knowledge translation piece. And you mentioned one barrier, specifically for this condition, this disease, stigma. However, you also noted some things that help facilitate that. You talked about feedback loops. You talked about clinical decision support and the electronic record. What are barriers and facilitators to truly implementing the evidence that you've generated? What have you seen? Because there are hospitals in this country who are adopting this evidence and who are implementing it into practice, and then there are others that are struggling. What have you seen works, and where do people struggle?
Well, honestly, they just don't get started. So what they need is one champion. They need one person in the ED, whoever it is, a nurse, could be a secretary, could be anybody, who wants to initiate a process. And then it takes someone to start that process. So the thing I hear mostly is, we don't have any place to send anybody, all right? Well, the government sent me to 4 large cities with one grant who said they didn't have anything, believe it or not. I went there. It's remarkable. I could tell you the story. So I'm in Baltimore, which has lots of treatment centers. They tell me they have nothing. They tell me they do send somebody to one place and they never take them. So I go to the place and I actually do focus groups with the people at the place. And they go, I don't know why that ED keeps sending me places because we don't take people off the street. I don't know why they don't understand that. We've told them 5 million times, right? People have to sit there for like 5 days, go through therapy without meds, and sit there withdrawing, and then maybe they take them. But once they actually take them, they're a great resource. They give them job training, medications, housing. Like, it's a really big deal. So we worked with them and said, okay, we'll give them the 5 days of medicine. Then we'll have them come sit in your outpatient, whatever, and then you could take them. Or I found other places that were very willing to take them. I found zillions of places that were willing to take them. And then I come back and I explain to them, here are the places that they can go, refer them there. I did the same things in Cincinnati. I did the same things in New York City, in an ED that was across the street from the very first methadone clinic. Didn't know how to send them there. Didn't know what happened when they got there. And again, that was a thing where you couldn't just walk in willy-nilly, but they did have a place on the 3rd floor that gave out buprenorphine, and they were very willing to take these patients. Just show them they show up any day before noon. We'll see them. Just come up here. So mostly I need some champion at the site. I need somebody to find out where those resources are so that people feel comfortable. But honestly, you send out a lot of people who don't have primary care. Do you ever say, what am I going to do? I'm not going to give them their antibiotic because I don't know if they're ever going to take it or go for follow-up? No, you don't do that, right?
Right.
You give the antibiotic anyway. So really, who cares? Start it and then get them somewhere. But if there's nowhere to go, they'll find some place to go or they'll come back and then you'll find it. But those are issues that people want to know. Where can they go? I don't think there's a place in this world I can't get somebody to. And people have called me. Sometimes it's far. It is far and it's complicated in the middle of, someone told me, I think it was Nebraska, I don't want to be wrong, but I found them a place fairly not that far that the person could go, that they were willing to go. So he said, you tell me where, I'll find you a place. There are a dearth of methadone clinics. Those are run, by opiate treatment programs, SAMHSA, whatever, and there are really difficult places in the country where they have deserts of those. But they have a lot of doctors and APRNs who now can give out buprenorphine, because in the past you had to do all this extra training. That was a big barrier. But we did away with that, and it's still not increasing the amount of bup. So that was just an excuse, honestly. Although where I trained at Yale, where I worked, I made every single doctor do it. I just gave classes, and they were passed and had the waiver. I'm not sure that made them do it until I was able to do stuff like the pathway, or that I badgered them over every patient that didn't get. So that feedback is incredibly important. So you got to get the director's line in it, because, and I'll tell you another quick story, like one of my directors who was very much against this, very much against my minute I walked in to Yale as a new faculty member, like would say, get that patient out of here before she sees, right? Or, I mean, literally, I worked nights. I kept a couple of people over because I found a social worker somewhere else who would come over in the morning. So I'd keep like maybe 2 or 3 people. And then he thought I left and he said, get those people out quick. She left, right? I was like appalled. But anyway, he was not, his job is to get people moving in and out very quickly. And he was one of the most earlier adopters, right? So I said to him, like, whatever, how come? I don't get it. He said, Gail, you gave me a way to get these individuals in and out fast, and they don't come back. I'm all for that. I'll do it. I'll do whatever you want if that's the case. And so that's what, made him rock. So I said, okay, I can do that. That's his thing.
Yeah, I want to follow up on that because you mentioned a few things. You mentioned one thing is that in the emergency department, we don't operate in a silo.
Right.
And however, sometimes when we are referring patients out to get follow-up care, if we don't understand the resources that are in the community, then that can be a barrier. And so it sounds like you had to overcome those obstacles and understand what was the system in that city, so that you could meaningfully refer as a person for follow-up. But then you also mentioned the challenge of getting someone to understand the importance. And I'm curious how you did that. Like you shared that the story of that director that was initially reluctant. What was it that eventually convinced them? Like, did you show him data? Did you,
No, unfortunately.
What did you do?
It was just getting people out. So I learned early on, just like individuals with substance use disorder, you cannot necessarily change everything about them. But you what you try to do is to make their life easier. And what is it about something? And you do this motivational enhancement to find out what it is that would make them better. Why do they want to make a change, not why they don't want to make a change? Like, what would make it easier for you, or why would you want to do this? And you expound upon that. So the same is really true. I can't make a doctor change their thoughts about stigma, but I can change the behavior of doing it, because I will give them a ding for not doing it, and I will torture them in a lot of ways if they don't do it, by quality measures, etc. So people don't have to like it or even think about that I've changed their mind in terms of stigma. I just have to make them behaviorally change a process and do it, because they're going to get patients in and out, and that's really important. And I did a study once with residents at 2 different institutions around alcohol, right? And I did, in one, I gave them a lot of training and whatever, and in another place I didn't. And I looked at what they did for patients by charting, right? And then I also gave all of them these kind of attitudinal scales, brief attitudinal scales. And what I really learned is I didn't change people's attitudes, but I changed the one place behavior, because they knew I was looking at them, because I told them what to do. I gave them the skills to do it, and they could do it. So they did it. But I didn't necessarily change their attitudes. So I just have to get the behavioral change. And I know it works. I use this example a lot because one of our other medical directors, who's great and sees a lot of patients, and he called me once and he said, what's the dose? And I go, like, what do you ask me what the dose is? You do this all the time. He goes, Epic's down, okay? I don't know. Just tell me what's the dose. So I know that he's doing it through the pathway all the time. But, he doesn't really know what or where or whatever, but it's getting people out. And that's what they're interested in. That's their thing. Get people in and out as fast as possible and keep those beds open. So I'm okay with that.
Yeah, and that's a great example of how that clinical decision support we rely on for something that is so core to processes of care.
Right.
I wanted to go back to something that you had mentioned earlier. You had talked about how or I might have asked this, when things started, it was really the crack cocaine epidemic that was going on when your interest in this began, and then things have evolved since then, and then heroin that became more prevalently used, and now with fentanyl and other synthetics being more of what we're seeing. How has that changed the pharmacology and the street reality of opioid use disorder? And what's the next hard question the field hasn't fully confronted yet regarding that?
Right. Well, even though we've seen somewhat of a decline, it's not over with opiates, right? So, and unfortunately, I think we're kind of ticking upwards. And a lot of it may just be because we can't get the precursors of fentanyl from China anymore. So the people who are making fentanyl out of a lab are having more and more trouble making fentanyl. So we cannot leave our eyes off that ball. We still have it. But now we have other things that are adulterants that are in it, which are difficult. Some we've had. They're all often sedatives that are veterinarian sedatives. So something called xylazine had been in a lot, particularly around the Camden, Philadelphia area. That caused a lot of wounds and things. We've always seen that. In New Haven, we see it. We don't really have those large amount of wounds. I think it actually has to do with how much is in a compound and how much they're injecting in certain areas. But we're seeing something called etomidate now, which is a much stronger sedative, which people have withdrawal states from. And so it's more difficult to know, are they withdrawing from that, or are they withdrawing from the whatever fentanyl or whatever it is. So it's never going to end, all right? So there's always going to be something. So we can't keep our eye off the ball for opiates. But also what's now is that stimulants, primarily methamphetamine and cocaine, are really rising. And in mid last year was the first time that overdoses related to those drugs exceeded those of pure heroin or fentanyl. So it's climbing. We unfortunately have no FDA-approved medications for stimulant use disorder, but we have to start thinking about that. Also cannabis, and I'm going to go into that a lot. Cannabis is a very difficult drug. It is a drug, all right? And it is has mind-altering substances about it. It's not good for your brain health. And if you think about what happened with the opiate epidemic, it was that kids got a hold of Percocet. That's how it started at first, right? A bunch of white kids got a hold of Percocet. And they thought it was okay when you talk about them and when you talk to them. And I talked to many of them, and that's many of who I had, people even that were on teams in college and football because they had injuries, right? But they thought that if your mom or your grandmother had it in their medicine cabinet, it couldn't kill you. I mean, some doctor prescribed it, right? It's a legal drug. Right. I'm not getting something off the street. And that's actually how we started, right? And then everything went downhill after that. But cannabis is very similar, right? Now that it is, quote, legal in many states, it's fine. It's legal. It can't possibly be bad for you. It's horrible for you, right? There's nothing good about cannabis. And particularly in both the younger population whose brains are just evolving and in the older population who, like me, maybe took it earlier on and thought that it wasn't so bad, but now it's 10% or 10 times more potent, and now it's in all different formats, and you really don't even know what you're taking. And there was just recently an article in a big paper that said they couldn't stop kids in high school from using. The teachers are seeing all their kids are high. They don't really know how to stop it. They're checking their backpacks, they're checking the bathrooms, and they're going into, like, I don't know, these bizarre places in the bathroom that they're finding cartridges. So it is horrible. It's just so you know a little bit about cannabis. There's about 60 million people who use cannabis, but there are like over I think it's like 20 million people who have an cannabis use disorder. Like, that's not possible. Like, when you think about opiates, 6 million, 5 million, 6 million. When you think about stimulants, 4 million, whatever. But you're talking about a use disorder, right? That means you got into some kind of trouble with it. It's not that you're just used it and you've never had any difficulties. It's a use disorder. So that is scary. That's really scary. And we're headed towards a really bad time because we're saying it's okay. And I can't tell people what's okay. Like, people ask me about alcohol all the time. So alcohol, there's a set amount that's in 1 ounce of distilled spirits, a normal 12-ounce can of beer, 5 ounces of wine. There's a standard. I can tell you what I consider low-risk limits for that. I can tell kids, you're really not supposed to drink. But if you do drink, like, keep it under a certain amount, right? I can't tell you that about cannabis because I don't know what you're taking. I don't know how much you're inhaling. I don't know what that is. I don't even know if you go and get it in a store and it tells you how many grams. I don't know what that means, right? So we don't have a way of even messaging this out. Like, what does it do to your brain? How does it know that you can't get in a car, that you don't want to be on the street where you're going to step off the sidewalk and you're going to get hit by a car? I don't even know how to approach that. And so we're going into uncharted waters for both young people and older people. And the horse is out of the barn. I don't know how to stop it. And people will think that I'm being crazy over it, right? But it's not. We're going to see that's horrible morbidity and mortality associated with it.
That's very sobering to hear your perspective on cannabis and then on substance abuse in general. And I'm paraphrasing a bit, but I think you said we're never going to completely fix it.
Right.
And that can be something that can cause us to lose hope. However, at the same time, I think we have this opportunity as well as investigators when we know that there's always going to be a problem that we need to fix.
Right.
And that we can do that through the evidence that we generate. And so I wanted to shift a little bit to thinking about that early stage investigator who's just starting out in their career in academic emergency medicine. And for them, there's often a tension between following the money, where can they find funding and where do those priorities exist for funding, and following the question that they really deeply care about. You built a landmark research program by doing the latter. What would you tell an emerging physician scientist who is trying to be strategic while also studying what they're passionate about?
So again, the conversation is always about tell me some things you're passionate about, and then finding a place which is actually fundable, because you need money to do it. But as people, I constantly say, it's not the money, it's the process. It's what you come out with and disseminate. It's the most important. But in order to do a large trial or to really do something well, more and more as things are going on, you need money to do that. So people will come to me with a variety. I just say, just throw some ideas out for me and tell me what you think. And then I can know, at least in the agencies that I know well, whether they would be interested in something, or we can call a project officer and say, what is? More and more now, with the way things are going with the NIH, we have to be sure that we're in their priority lane. Don't submit something that's innovative, not in their priority lane, because it's not even going to go anywhere. There'll be less and less general program announcements. They're going to be more directed RFAs, so we have to be careful with that. So when you think about the world and what we need, and I was remiss in not saying this about substance use, half the people take it to feel better and half the people take it to feel good. So there's a lot of mental health involved in those people who use it, or other illnesses like ADHD or something. So we have to be really careful that we have people studying the mental health process, because our EDs are overwhelmingly filled with patients, right? So that would be an area. So if people came to me and said, I want to do something around depression, anxiety, whatever, great. right? Anything that one could do of the patients that we see there, anything in the things we've talked about in substance use disorder. Lots of things can happen in your own field in pediatrics. Like people are interested in adolescent brains and what's happening with them, and a variety of different things from injury through substance use. I'm sure now it's going to be what happens when no one gets vaccinated. I'm not sure we'll find anybody to give us money for that, but we're in for a long haul with diseases that we've never seen before. So what are we going to do about that? So there are questions, and it has to match their passion, but also in an area where an agency is interested in that.
That's wise advice. And you have had an impressive career. You've accomplished so much. And looking back now at your own arc, nurse, consultant, physician, researcher, department chair, National Academy of Medicine member, what do you know now about how careers like yours actually get built that you wish someone had told you earlier?
I think one of the first things is the importance of preparation, which we didn't know that before. So people have to have real coursework in research process, and whether it's getting a MD, PhD, or it's getting any kind of Master's of Health Sciences, or whatever it is that you want to do. You can't just go out there and wing it, right? You've got to have the preparation that is there. I always say we need a lot of things, but one is passion, so you need to do that. And then we need perseverance, because there's a lot of trials and tribulations of doing that. And you need a lot of people to help you. And lastly, you need to withstand a lot of pain, because that's what's going to happen. But mostly, I think if people know, you got to start early. You got to have the preparation and get that. Find yourself some mentors that are going to help you out. And they don't have to be actually right at your place. They can be somewhere else. But there's someone who's going to look after you, give you some good advice. Seek out everyone. I mean, I do that even now when I'm trying to think about a project. I call someone who's an expert in a particular field to know learn something more about it than before I start pontificating or reading the literature. I need to know where to start. So we have to reach out and make sure you get a large group of experts in those areas before you decide to think about what area you want to accomplish, because you have to know what has already happened and what the gaps are and what is potentially that you could fill that gap. And it's very doable, and it's great. And sure, it's overwhelming, but it can be just a wonderful thing to say that I've done something. I looked at some problem and I've brought that to somewhere along the way of getting to a better place and improving people's health. So I want to make sure people are excited about it. And we need people in emergency medicine. We need pipelines of people who are going to go out there and have this curiosity of what is it that you want to study. And almost always I can fit that into an area that is fundable.
Something that I appreciated about what you said is that, yes, it begins with curiosity and passion, but research is also a team sport.
Yes.
That it requires mentorship, collaborators, and engagement with the community. We spoke a lot today about things that can bring us down: substance use, mental health. I'd like to end on a positive note, because I do think there is hope in the work that we do. And so what is it that keeps you inspired, and what gives you hope?
Well, what keeps me going, honestly, is that there is always something else I feel like I could do. Like right now, I'm really looking forward to try to use GLP-1s in stimulants in cannabis use, and things that we don't have FDA approval for. I think it's also great for alcohol, and we're testing it. People are testing it now with opiates. Like, could you use buprenorphine and a GLP-1? Because we know that people aren't retained as long on these medications as they should be. Why did they go off? What are their other reasons? These new medications have do something with the dopamine and reward circuit and the cues and the craving. And it's kind of a track that is there for really all different types of, it's transdiagnostic, I guess is the best way of saying that, for all substance users. So that to me could maybe help people that we would not been able to help before, or we don't have medications for. So what keeps me up is that I keep thinking of another idea, right? And also because I have great young faculty around me and they have great questions and they want to move forward. So just watching them and helping them move forward, because they're the next generation of people who will improve the health of the public on a variety of different things, is pretty exciting. I'm never discouraged about the fact that there's possibilities. I just need us to make sure we have the departments who are willing to put an effort into it and provide some of the resources that are available.
That's exciting. New ideas, great questions on the horizon. The field of medicine is constantly evolving, and specifically emergency medicine as well. Well, that's a wrap for today's episode. Many thanks to Dr. Gail D'Onofrio for sharing her insight, experience, and perspective with us. Thanks as well to all of you for listening to the Stanford Emergency Medicine podcast. If you enjoyed the conversation, we encourage you to share the episode with colleagues and trainees who may found it helpful. We appreciate you tuning in, and we look forward to bringing you more conversations with leaders across emergency medicine. And as your regular host, Dr. Matt Stralo usually closes the podcast, keep taking care of anyone, anything, at any time.